Good morning and welcome to this ultrasound video series. We're going to be talking about the extended FAST exam. My name is Juliano Deportu, and I'm one of the ultrasound faculty here at the University of Florida, the Department of Emergency Medicine. So we're going to talk about why we do the Efast, the views that are included, the normal anatomy, and obviously some pathology. This is one of our trauma bays here at the University of Florida, where you can see that the ultrasounds are integral in our daily workup. So FAST stands for Focused Assessment Sonography in Trauma, and it's been shown to be more accurate than a chest X-ray when you're looking for pneumothorax. It is very sensitive and specific for free fluid in the abdomen. You can see as little as 100 mLs of free fluid in the abdomen. It's rapid. The more you get used to doing them, you can do them in, even under 2 minutes, reducing the time to definitive care. It's non-invasive. It has replaced a diagnostic peritoneal lavage in modern trauma care. You can obviously repeat it if there's changes in patient's condition, and it's portable. We have handheld devices you can take to the patients. So we're going to talk about the indications for the extended FAST now. Let's say you have a gentleman that rolls into the trauma bay looking like that. You can see that he has a seatbelt sign, so it's very concerning for injury. So the FAST exam will be looking at structures within the abdomen, but is not really, we're not looking at structures in the retroperitoneum, okay? We look, one of the views is the cardiac window, and when we have injuries, penetrating injuries within the area called the box, that's an area defined as the bounded by the anterior chest and by the clavicles, laterally by the midclavicular lines, and inferiorly by the kind of an imaginary line drawn between the costal margins. You have that area. It has been shown that there's high probability of direct cardiac injury, so we want to look at the heart as part of our FAST exam. And what we might find is, for example, fluid within the pericardium. So review, fluid is anechoic, and it has sharp edges and is dependent on the anatomical structure. So we can identify free fluid in the pericardium. We can identify free fluid in the thorax, free fluid obviously in the abdominal cavity. There's an example of a ruptured ectopic. You have the uterus on the right side of the screen with an area, a large area of free fluid. And we can also look for pneumothorax, and we'll show you how to do that. So again, fluid is anechoic, dependent, and has sharp edges. You see a kidney on the right side of the screen with a liver, and that free fluid in the middle, in the hepatorenal space. So we use it in blunt trauma and during unexplained hypotension and trauma in pregnancy. And you can use either the phased array or the curvilinear probe. Some places only have the phased array, but any of those two could be used. And basically we have 5 imaging windows. You have the subxiphoid, looking at the heart from the subxiphoid area. You have the right upper quadrant. You have the left upper quadrant. And you have the suprapubic. And in the extended FAST, we look at the lungs on both sides. So let's start with the cardiac subcostal. You're going to be looking at the heart. You're going to see the liver on the superior portion of your screen, and then you have the right ventricle, the left ventricle, the right atria, and the left atria. And when we're doing the FAST exam, as a kind of reminder, we're just looking for free fluid and to see if there's cardiac activity. We don't want to look at valves and all those additional things that we could technically do during an echo. cardiography, we're just looking for free fluid and cardiac activity. So let's move on to the cardiac parasternal long axis that we could also do in the setting of trauma. If your patient has a distended abdomen or has a lot of air artifact, you just want to look at the heart. So you can go through the cardiac parasternal, and you go at the level of the fourth or fifth intercostal space, parasternal, and you should be able to see, the heart. And the superior portion of your screen is always where your probe is touching. So in this case, you would be looking at, the muscle wall, and anatomically, the right side of the heart is the more anterior anatomically. So you're going to be looking at the right ventricle. So you're going to be looking at the right ventricle, and as you go deeper, you're going to see the left ventricle, the left atrium, and you should be able to see the aortic outflow tract. You want to be deep enough that you are able to see the pericardium. The pericardium looks hyperechoic, and you don't want to be superficial, because if you do have a pericardial effusion, it's going to be, just by gravity, it's going to be in the posterior portion of your screen. Then we move on to the right upper quadrant to look at the hepatorenal space. You see the kidney, the liver, then you see the diaphragm as that bright hyperechoic structure. And then you're looking at this space, the hepatorenal space, which is the anatomical space that's more posterior. So that's where the blood is basically going to pool. It's a more dependent anatomical space there. And when we look at the right upper quadrant, I just want to make the distinction that we need to look at three main areas. We're looking at the hepatorenal space, but we also want to look at the chest and at the paracollic gutter, because we sometimes see fluid very prominent there in the hepatorenal space, but we could have a hemothorax, we can have a small amount of fluid just on the paracollic gutter. And again, as a reminder, anything that you see behind this line, it's basically in the retroperitoneum. So you might find, like renal abscess, renal cyst, but nothing that is actually of clinical significance, probably during the FAST exam. So then when we move on to the left upper quadrant, just as a reminder, the spleen is going to be a little bit higher on the left side, just because the right side you have the liver. So, but you're still looking for that splenorenal, interaction, and you're going to look at the diaphragm again. And on this side, you also see the splenorenal part, but you want to make sure that you look at the area over here that's more dependent for fluid. And then you move on to the pelvis, and you can do sagittal, like in this case, with your indicator pointing towards the head. You see the bladder, and then if you rotate your transducer with your indicator towards the patient's right side, then you're going to have a kind of a transverse cut, just like the ones that you would see in a CT scan. So you're looking at the bladder, and it's going to be that hyperechoic line. It's going to delineate the bladder, okay? So when we're doing the extended FAST exam, and you can still use the phased array, if you do have the high frequency, linear probe, you can also use it. And what we do is we want to look at the pleura, the movement of the pleura. So what you do is you find your spot between two ribs, and ribs are hyperechoic and they're bone, and usually what happens with bone is that you have an underlying shadow, so you know that you're between the ribs, and you're going to be looking at movements of the pleural line, okay? And let's carefully look, and you see when the patient takes breath in, breath out, you're going to see that bright line, the pleural line, moving back and forth. This is another view. When we're obviously able to visualize that, when we're recording images, we want you to do the following: is we're going to find that good space in between the ribs, and then you're going to place your probe You see you see the lung sliding there. But since we're not able to save videos to the PACS, the radiology department, we're going to take a picture. Okay, so we're going to use our M mode, which M stands for motion. And what we see is an area that is static. Then you see the pleural line, and then you see the movement back and forth of the lung, and what we call that the seashore sign. So if you look from above, it's like seeing the ocean waves coming to the sandy beach. So let's review some normal anatomy, okay? So we're going to start with a subxiphoid view. When your indicator, you want to be as parallel to the skin as possible. Remember, your transducer is kind of like a flashlight, so you want to be looking at that structure, and that structure that you're looking at is a very, very thin, probably 2-3 millimeters in thickness. So you want to really make sure you get the best view there. And as a review, you have the liver on top, you have the right side of the heart, and then the left side of the heart. And one common pitfall is that some people see this area surrounding the heart on the superior portion, and people get it confused with is it a pericardial effusion or not? Remember, fluid is completely anechoic and dependent. Some folks, and we probably all do to a degree, have epicardium, pericardial fat pad. So you see that area that looks like there's fluid, but if you look closely, you'll see that there are internal echoes. A little bit of kind of a haziness there. They're called internal echoes. So it's most likely to be the pericardial fat pad and not actually free fluid. We're looking at the right upper quadrant, and then you see the hepatorenal space. And as you can see, we're fanning our probe, kind of looking through all the spaces. We don't want to just take a quick glance and not actually scan through all the anatomy. Okay. This is another normal view. You have the kidney, the liver, the diaphragm. We move on to the left upper quadrant. You have the spleen, kidney, nothing, no free fluid. You move on. It's another view. This is another view. This is a sagittal view when you have the uterus and then the bladder on the right side of the screen. It's anechoic, and then you can see sagittal view of the uterus. This is a transverse view. Again, we're sweeping through the areas, looking for free fluid. Actually, that's more uterus. And then kind of near the end there, you get a glimpse of the bladder. We're looking at since we're doing the extended fast, now we're looking at the chest. You clearly see that I'm deep enough that I'm going to see the space between the ribs, and you saw the pleura moving there. So some pathology. So this is subxiphoid view, right? And now it's looking very different. When you look at radiology, you'll see normal pictures, normal images, until you see something that's abnormal, and you might say, well, I don't know what that is, but that's not normal. So we want you to obviously be able to identify this is the subxiphoid view. So we have the liver, kind of the right side of the heart, left side of the heart. And, there's something that's wrong there. There's an anechoic area around the heart. And if you look closely, what's happening is that you obviously have free fluid. And if you look, you're very attentive, the right ventricle doesn't seem to be expanding properly. And that's because it's trying basically to fill during diastole against a pericardium that's full of blood, and it's having difficulty there. Those that we'll talk about, in the echocardiography, could be obviously potential signs of tamponade in ultrasound. This is another view of this is the parasternal long axis, and as you can see, there's an anechoic collection there. We are deep enough that we can see the pericardium, and we see the collection. So again, as a review, right ventricle, left atrium, aortic outflow tract. You have free fluid, and we use a landmark, and we use this structure here. That's a descending aorta, and we use that landmark because if we do see free fluid above the descending aorta, we can definitely say that it's pericardial in origin. If it's below the descending aorta, then it's a pleural effusion. I've seen patients with both pleural and pericardial, so but just use that as a landmark. Okay, that's your descending aorta. So again, we want to like be very, very careful when we look. This is the right upper quadrant, and this is what seems to be a great, right upper quadrant view, kind of almost picture perfect there. You have the liver, the kidney, the diaphragm, and if I were to only look and not really scan and move my probe around, I would probably miss that. And that's obviously a completely different scan. That's obviously a positive FAST exam. And it's just remember to sweep and scan around, okay? When you get the hands on, you'll see what I'm talking about. You'll get a little bit more of a feel. Again, I'm moving around. You see the kidney, and you see that dark area of fluid. Another one. Liver, kidney, the diaphragm over here, and the free fluid. We continue to see some pathology. This is a little bit more subtle, where your kidney and free fluid. So when we mentioned earlier that we want you to look at the three areas, the chest, the hepatorenal space, and the paracolic gutter, when we're looking at the chest, normally we have what's called mirror imaging. We have the liver and you have the diaphragm, and it appears that you have liver on both sides, and that's because the machine kind of interprets the signal along the diaphragm and creates a mirror image. So artifacts in ultrasound, we use them to identify normal anatomy. When we have loss of those artifacts, like in this case, then it tells us that there's something wrong. So what happens here is that we have the liver, the kidney, then we have the diaphragm, but instead of having liver on both sides, we have, a dark area that's anechoic, and that's basically free fluid in the thorax. And in the setting of trauma, this is a hemothorax. Pleural effusions will look just like that, but in the setting of trauma, I want to repeat again, you have to think that it's blood until proven otherwise. Okay, so you've lost the mirroring, and we also have another sign, which is called, continuation of the spine line. That bright line that's coming inferiorly from the kidney, liver, and now kind of continues up. It's another sign that there's fluid in the chest. Obviously, you have the spine goes all the way up, but it is kind of blunted by the mirroring effect. So when you lose a mirroring effect, you can actually see the spine continuing superiorly in the body. Again, kidney, spleen, diaphragm, and this is kind of a very subtle, free fluid collection there on the kind of more towards the paracolic gutter also. This one is tricky. This one, let's say this patient was in an MVC and has been transferred. So you see the kidney, you see the spleen, and there's something there, a little bit kind of a, there's some echogenicity that doesn't look quite right. That's actually like clotted blood. It's free fluid, but it's actually clotted. It's kind of a tough one there. Another one, very, very obvious, spleen, kind of floating there in free fluid. Better have a trauma surgeon nearby for this one. And again, this is a sagittal bladder, and if you look carefully when you sweep around, you see the free fluid outside. This is what we call, this is a transverse view. This is what we call kind of like the double bubble sign. You only have one bladder, If you see two bladders, one is obviously free fluid. And let's say this patient's coming in, had some blunt trauma to the chest. When you're doing your extended FAST exam, and what's going on? You have the ribs, but you don't really see a lot of lung sliding there, right? So there's no lung sliding. And if we put the M mode, instead of that, seashore, sandy beach, and the water coming, we have what's called a stratosphere sign. There's nothing there that appears to be moving. And, if no one believes you, they're still going to go for the pan scan, and that's okay because you knew already that the patient had a left-sided pneumothorax. You can see it there on the CT scan, but you've been able to diagnose before the CT. So kind of as a review, the FAST exam, you do it on unstable. You'll do it on every trauma patient. If you're unstable and it's positive, you're going to go to the OR, right? If you're stable, the surgeons might want to, run you through the scanner to see if there's any other traumatic injury. Remember, the ultrasound is great. It'll pick up, the free fluid in the abdomen, but it's very, very low yield for like solid organ injury or like mesenteric injuries. If you have a hematoma within your bowel wall or anything in the retroperitoneum, it's obviously not indicated. So you'll need another imaging modality such as a CAT scan. So if your FAST is negative and you're still unstable, you can always repeat it or consider other causes of, in this case, probably hemorrhagic shock. And when you do ATLS and when you review all those mechanisms, you can think about all the other areas in the bodies that you could be, bleeding from, losing volume. If you're stable, you can observe the patient. And again, differentials that could cause your patient to be in trouble: tamponade, tension pneumothorax, hemothorax, and all these other things could be, causes of hypotension. But always think that in the setting of trauma, hypotension is caused by hypovolemic shock. We use it during codes, cardiac arrests, and this is a subxiphoid view, and you have the 4 chambers, and fortunately not a lot of activity going on here. Okay, there's maybe a little bit of blood, a little bit of movement. Sometimes it occurs because of ventilatory efforts from bagging the patient. So nothing going on there. The diagnosis there is a cardiac standstill, and they've done studies on cardiac standstill and obviously very, very poor prognosis. All right, so let's run through some cases here. This is a left upper quadrant. We're going to see a bit of the kidney here, spleen, and we talked about the mirroring effect. So if you think about it, you have loss of mirroring. There's an anechoic area right there. So that's it's a large hemothorax. It's another one, right upper quadrant. You have the hepatorenal space. You have the kidney on your right side of the screen, liver on the left side of the screen. So you have a dark anechoic area here. There you go. That's a positive FAST exam. So now this is a extended FAST. We're looking at the chest. Up here we have the chest wall, and we have a rib here, a rib there. You have the characteristic shadow under the rib, and then that's a pleural line. Do you see any lung sliding? No. I agree. There's no lung sliding, so that's positive for pneumothorax. Again, this is another view, splenorenal area, and then you can see there near the paracoelic gutter, you see that anechoic area. That's another positive FAST exam. Left upper quadrant, there's no intraperitoneal blood, right? You have the kidney, the spleen, but then you have the chest, and then you lost mirroring, and you see this structure moving here. That's a lung moving. So you have basically a hemothorax. In the setting of trauma, it's always going to be blood. Another one, tiny, very, very subtle, but there's fluid there in the pouch of Morrison's or the hepatorenal space. And this is a subxiphoid view of the heart. And what's going on there? Is there an effusion? First thing, is there, let's say first, cardiac activity? Yes, obviously. Then, do we have an effusion? Well, yes, there's an area of anechoic around the heart. It all goes down, all the way. Your image goes down to the pericardium, very important. So you're able to actually visualize. If you were scanning or up to here, you would miss that part. So what's happening with the right ventricle? So right ventricle seems to be collapsing, there. So maybe tamponade. Tamponade is obviously a clinical diagnosis, but concerning looking. Okay. It's another case. What do you guys think? You see the kidney, you see the spleen. Do you see any areas that they're anechoic? Nope. No. We have to throw in, a normal scan every once in a while. This is like one that I was showing earlier. You have the right upper quadrant. That looks great. But when you look around, you do see that there's kind of a catastrophe going on. And I show you the clip. You'll see segments that appear completely normal. And then when you move around, you're able to move around. Then you see that there's fluid everywhere. Okay, so be very careful. And remember, this is a dynamic study. We're looking at the 4-chamber view, subxiphoid. What do you guys think? So that's a normal, no pericardial effusion. You have the 4 chambers. Review right side of the heart, left side of the heart. Normal exam. What about now? So this is a parasternal long axis, right? You have the right side of the heart on top. You have the left ventricle. You have the mitral valve and the aortic outflow tract, but basically you have your descending aorta here as your landmark, remember? So there's an area that's anechoic here above the descending aorta, so that's a pericardial effusion. This is an interesting one that I want you to look at. This is a left upper quadrant, and this is a concerning area, right? There's something going on there. You might not know what it is, but it's definitely not normal, you would think. So if you're looking at the left upper quadrant and your probe is pointed, kind of anteriorly, you might catch a glimpse of the stomach. And that's what you're looking at. Obviously our patients are not, NPO before they're crashing into a tree. And sometimes that's probably beer, if I were to say something. And so there's echoes in there. That's a stomach bubble. So if you see it, don't be alarmed. You'll be able to recognize it. This is another one of an extended fast. And if you look closely, there is movement. Let me not stop it for you guys. Very subtle, okay? But that's no pneumothorax. This is maybe a closer view. And you see lung sliding. And if we do the M mode, you see again, this is the seashore sign. This is the waves coming over to the sandy beach. Again, this signifies that there's a static chest, wall, muscles, etc. This is a pleural line here, and there's movement back and forth, and signifying a normal exam. Parasternal long axis. What do you guys think? That's pretty normal. This is a right upper quadrant. Kind of like looking around. You see the hepatorenal space. You see that there's mirroring, that there's no continuation of the spine line. You catch the IVC and the aorta right there, but negative exam. This is a little bit kind of tricky, but interesting. So this is a transverse view of the suprapubic area. So you have the bladder, right? And then when you're looking around, you see kind of something like kind of down here. That's not truly 100% anechoic. There's some components there that are anechoic. So let's say this is a patient that gets transferred from another facility after suffered at MBC. So this is clotted blood there in the pelvis, okay? Interesting. And let's do maybe one more. Left upper quadrant, hemothorax, okay? And a little bit of a subphrenic blood there. Very subtle, okay? This is I think it might be the last one. This is right upper quadrant. What did we talk about? This is very subtle, but you guys are going to be pros at doing ultrasounds. So you have the liver. Did we lose mirroring? We did. There's a small area that's anechoic there, loss of mirroring, and you have continuation of the spine line. So that's fluid, and in the setting of trauma, that's a hemothorax. until proven otherwise. Left upper quadrant. You guys think that's, you know, normal exam? All right, so we'll do some hands-on in the lab, and we'll see you soon.